But if you choose to participate and prefer not to have your image and likeness displayed, there are visual and audio settings on your device that you can use to block your picture and mute your voice. So everyone's audio is being muted upon entry into our room by our technician. Thank you, Simon. We ask that you remain muted until the host or facilitator asks you to contribute in order to minimize the distraction of background noise. So check and make sure your device is on mute at all times until called upon to speak, and then once again, place your device back on mute when you're done speaking. As for the chat room, if you have questions, you can enter them into the chat room, but please limit your questions to 2 questions per topic being addressed at one time. And please do not use the forum to advertise or promote your products so we can stay focused on the topics at hand. Understand that there may not be sufficient time to get all the questions answered during the call, but we'll do our best. So lastly, well, second to last, Black Health Trust needs you to continue bringing our community outstanding programming, critical and timely information. Please visit www.blackhealthtrust.org because we need your support. Visit the website to learn more about our programming, how to support, volunteer, and donate, especially so that we can get this information out to as many people as possible. Visit our website, blackhealthtrust.org, to donate via credit card or PayPal, as well as Cash App. So thank you so much. I want to thank the Black Health Trust Steering Committee, administrative assistants, our virtual Zoom technician, and all the people behind the scenes for their time and efforts to make this programming possible. And I want to give a big, huge welcome and thank you to all of our distinguished physicians and special guests today. We thank you in advance for sharing your valuable time, your information, and educated insights with us. Your participation and support helps empower our communities of color, and this is critical to our present and future well-being as a people. So knowledge is power, and we thank you. Welcome again, everybody, to Black Health Trust's weekly program. Grab your coffee, tea, get comfortable, lean in. And Dr. Maxey, please do us the honor of moderating the program.
Thank you very much for being our wonderful and beautiful hostess today. Miss Michelle Simmons, who is the mother of 2 super genius young sons who are making their own mark in the world as young Black men. Welcome everybody on this Sunday. We're glad to have you with us, and we hope to give you very important and timely information. And looking at all of the news this week, we see that this COVID-19 is still alive. And I recall some months ago seeing a picture of a number of bishops and officials of the Church of God in Christ who, against better advice, attended a funeral of one of their colleagues. And a large number of them, 8 or 9, died. There are many of us who are people of faith, and we believe that we have a certain amount of protection. But it is clear that it does take common sense with this virus. It has no respect of the earthly things that we call political parties, or that we're the great United States, we're Republicans or Democrats or agnostic or whatever. We advise everyone to use the appropriate measures of social distancing and cleanliness, clean hands and eating correctly. And when I opened up my electronic Bible to read for the day, I came up with a verse. And that verse is in Luke 4. And it's when Jesus returned from the Jordan River and was led by the Spirit into the wilderness. And he was tempted by the devil. He was hungry, he had fasted for more than 40 days. And I'm going to skip to verse 9. And in that particular verse, the devil took him up to Jerusalem, to the highest point of the temple, and said, "If you are the Son of God, jump off. For the scriptures say, he will order his angels to protect and guard you, and they will hold you up with their hands, so you won't even hurt your foot on a stone. And Jesus responded, the scriptures also say, you must not test the Lord your God. When the devil had finished tempting Jesus, he left him until the lesson point in there, don't tempt fate. Keep yourself safe. Keep your family safe. Regardless of what you may see on the TV and on the news and people deciding that there is no significant death rate, the statistics say there's only a small percent of people dying. First of all, that's not true, but if that percent is you or someone you love, that's a very significant number. Don't tempt fate. Don't test the Lord your God. Uh, Simon, can you go to the first slide, please? This is it. The total cases of COVID in the United States as of midnight were 8,081,489. There are also a number of new cases. I won't read them to you, but we've had well over 300,000 deaths so far. So this thing is killing people, and it's killing your people. It's killing our people. We know that there are a lot of related items to keeping your family safe and our community safe. And we've invited speakers every week that have relevant topics about the problems that result from being locked up, being social distance, of not being able to participate in our normal social activities. So we'll get right to the subject. You feel free right now to email or text somebody else the link to this Zoom call or to our Facebook or streaming live on LinkedIn so they can get this information. In addition, they can go to blackhealthtrust.org. We're now a certified 501c3, and they can find the streaming live on this topic. We thank you so much. I'm going to introduce my co-moderator today, who's Dr. Barbara Nabrett-Stephens. She is a noted specialist in pediatrics. She is a healthcare executive with a large company in Tennessee. I'll let her introduce herself in a moment, but I've known her since she was, I shouldn't tell it, but she was 15 years old and now she's almost 21. Dr. Barbara Nabrett-Stephens, and I'll ask her to introduce our guest.
Good afternoon, everyone. Thank you so much for tuning in to our program this afternoon. Our intent today is to try to focus the information distributed and the concerns around parents and children. We want to try to identify and provide pertinent information for parents to take into consideration as they're trying to protect their children, as parents are wont to do. We also are going to try to address some of the questions that our kids have about what's going on around them. This is certainly a complicated life that they have been born into, much more complicated than my childhood for sure. But I would hasten to say that as a people, we have had to struggle and not only survive, but thrive in challenging times. That's nothing new to us. And I believe in my heart that because of our history, we have developed the skill to be resilient, and that resilience will continue to take us through. Our participants today, I'm very happy to present our first presenter is Dr. Vi, who is a psychologist specializing in pediatric neuropsychology. He is a professor of psychology and behavioral neuroscience at Florida Memorial University in Miami, Florida, and has been active throughout his career in comprehensive neuropsychological issues and psychophysiological intervention for children with traumatic brain and spinal cord injury and neurologic and neurodevelopmental disorders. He has rave reviews regarding his counseling throughout the years, and we are confident that he will share with us very helpful information guiding us through these difficult times. Our other speaker is Dr. Alpha Stewart, who is a Senior Associate Dean in Community Health Engagement at University of Tennessee Health Science Center in Memphis. She is a pediatric psychiatrist and has worked long and hard addressing the issues of our children, and is very active currently in ACE's work, which we have discussed previously, and has special interest in trying to divert and avoid our kids' entry into the juvenile justice system through various preventive programs. She is a past president, in fact, she was the 145th president of the American Psychiatric Association, for which she is the first African-American to hold that position. So I am very, she's also past president, I don't want to forget, of the Black Psychiatrists of America and recipient of their Lifetime Achievement Award. So as you can tell from these synoptic bios that I gave, that both our presenters are eminently qualified to give us information and direction on how we can best support and guide our children today. We will start with Dr. Vi.
Thank you so much for that introduction. I truly appreciate it. I'm very humbled by this opportunity to present today. I want to definitely thank Judy Maxey, who I've known for some time now. And it's through her knowing me and her confidence in me being able to present, which is why I'm here. So thank you very much to Dr. Maxey for your fine work in this great endeavor to enlighten and empower our community with information that they normally would not receive. So thank you so much for this opportunity. I'll be speaking today on pediatric neuropsychology simply because there's a lack of knowledge in our community in terms of what we do as specialists in the field. I will be brief as I can and pointed. Some of the slides may be a bit wordy. I'll try my best to summarize those to make it useful to our audience. Next slide, please. Okay, so we look at pediatric neuropsychology. Basically is the study of brain function as it pertains to the pediatric population. We are specialists in the field of medical psychology, and we are interested in both neurodevelopmental disorders and neurological disorders. particularly when it pertains to children who are having difficulties in school, because often these problems that children are having in learning and or behaving is assumed to be psychological in nature, when in fact that these are neurodevelopmental disorders or neurological disorders. So we're interested in neuropsychiatric disorders, attention deficit, traumatic brain injury, acquired syndromes, particularly those syndromes that involves teratogenic substances, which embryos are sometimes exposed to: alcohol, cocaine, and lead, exposure to radiation. So we really run the gamut in terms of looking at all of the areas in which we find children having some types of behavior or learning difficulties. Next slide. The field of neuropsychology has greatly been enhanced by medical technologies, particularly scanning devices. We have functional imaging, which is a little bit different than an MRI. Functional imaging are images where we're looking at metabolic activities of the brain. We go to some of the more newer techniques of magnetoencephalographs, which are typically used for patients with depression. And these non-invasive techniques, particularly MEG studies, clearly show we're not responding to medication to treat clinical depression. We look at positron emission tomographies to get good contrasting studies of brain activity, regional brain flow, cerebral brain flow studies, and we can look at regions of the brain where you do not have adequate blood flow to a particular region. This is called hypoperfusion, and we see this in many disorders of childhood where regular imagings are not telling the full picture. Okay, next slide, please. We know that brain functioning has a direct impact on behavior and cognitive and psychosocial adjustment of children. And so we want to integrate those factors in order to better understand why the child is having a problem and what type of interventions we can provide to remediate or alleviate those problems that they're having. Psychosocial adjustment in the communities or at home, learning problems in school. I'll show you a few slides of what it looks like to be a child with dyslexia, where again, children with reading disorders, and I definitely do not have the time for that today, but perhaps at another time I can speak specifically on reading disorders and their complications, because children who are having reading disorders are sometimes grouped as one without the understanding that you have different types of reading problems depending upon the region of the brain that has been impacted. So we know, for an example, that we are concerned ourselves with functional activities of the brain because we know that cortical and subcortical systems in the brain can have a devastating impact on children's adjustment. Next slide. Again, so we look at, so we take a look at the techniques that are involved, and we definitely look at all the factors that could affect the child's development. Psychosocial, environmental, we look at neurocognitive, we definitely look at biogenetic factors. Biogenetic factors, these are factors that can impact the child from a genetic point of view as well. So we concern ourselves with these different types of behavior, and what we want to do as neuropsychologists is we want to integrate and combine physiological and psychological systems and incorporate those systems to get a better understanding of behavioral techniques or behavior systems. Next slide. Okay, I'll deal with that. Michelle wants to know the role of executive functioning. I'll talk about that in just a moment, Michelle. Thank you. Okay, next slide. Next slide. Okay, so so attention deficit disorder is a neurodevelopmental disorder. We try to distinguish between neurological disorders or diseases versus neurodevelopmental disorders. What is a neurodevelopmental disorder? Well, a neurodevelopmental disorder is one in which there's been some type of aberration during brain development in which systems do not functionally operate when the child is born. So we can take a look at, for an example, the mother's history, and we can know, for an example, if we look at the child's prenatal history, and if the mother has a clean profile for adequate prenatal care, for an example, we look at the environment in which she became pregnant, we look at the home environment, and when we rule those things out and we find children later on, particularly when they enter into preschool programs, and many of these disorders are manifesting themselves in preschool. So when we do a family history and we find that the child's prenatal history is relatively clean and the child is having these problems, for an example, like attention deficit disorder, this is an example of a neurodevelopmental disorder. So there's something that occurred during brain development in which the brain fails to have adequate cortical functioning, and you have this many type of disorders. Attention deficit is one of them. So we know, for an example, that central nervous dysfunction, we know now from studies that central nervous system dysfunction can be attributed to significant problems with learning, particularly with children with reading disabilities, math disabilities. These are called reading disorders, are called dyslexia. Math disorders is called dyscalculia. And because of the separation between brain function and behavior, educators tend to miss the mark, particularly when it comes to intervention. So if we assume that the child's problem is related to the teacher, or the child's problem is related to perhaps poor parenting, without understanding the biological basis of that child's problem, then the intervention can be quite inappropriate. Next slide. Good example of when an EEG is normal and yet abnormal. Okay. Well, what do we mean by this? Well, this is a quantitative profile, EEG profile of children 9 and 14. And you look at number 1, this is a good, beautiful picture, an EEG profile, which is enhanced in color to show brain functionality, which you typically will not see in a regular EEG. So we color coded just to show the brain activity. And you see this is a normal 14-year-old female with a really good activity in the frontal cortex, you see in green. And we see, for an example, beautiful red in the posterior region of the brain, which is what we would like to see in a normal brain profile. Posteriorly, high alpha activity and good beta activity in the frontal cortex. And then in number 2, you see a child with this is a normal brain profile of a child with low alpha wave activity, which is good because we want to see more beta activity, particularly when the patient is awake, as opposed to when the patient is sleeping with eyes closed, eyes open. But then we see picture number 3, we see here's a 14-year-old female with an abnormally high theta activity in the brain. Well, this is an abnormal activity. In fact, if this child had a regular EEG, the brain profile will look normal. So a parent can have a neurological evaluation and have an EEG is typically requested. This is something that I do routinely. I always want to see a picture, at least an EEG of the child's brain activity. And then we enhance the brain activity by doing a quantitative analysis, which you're looking at this particular time. So,
Doctor, can you explain what an EEG is?
Yeah, okay, I'm sorry. This is an electroencephalograph. These are recordings of brain wave activity. And you have different bands in the brain, beta bands, theta bands, alpha bands, and delta bands. And basically these are different brain wave states that have specific behavioral correlates. So for an example, if we say beta activity, when you're in your waking state, we expect to see high beta activity. Beta activity refers to an individual who is alert and focused on the activities going on around him or her. Good concentration, good ability to attend to specific information that's being presented. If you take a look at, for an example, slide number 3, where you see there's a lot of red activity. This is high theta activity, which is a bad profile because theta wave activities are slower brain waves. And so the child tends to be sluggish. This is a good profile of a child with attention deficit without hyperactivity. ADD profiles look different than a child with ADHD profiles. So you're looking at in slide number 3, this child has ADD, and this child would be typically lethargic at times, inattentive, doesn't quite pay attention to what's going on around him or her. Now, I want to qualify this by saying again, if this child had a regular EEG profile, the EEG would come back normal. Neurologists tend to look at seizure activity. Neuropsychologists look at brain functioning. So even though she has a normal EEG profile because there's no seizure activities, yet in quantitative EEG profile, you can see that it is abnormal. And then finally, you will see the reverse asymmetry. If you look at pictures 1 and 4, you notice that green activity in the frontal region of the brain, the frontal cortex, good theta, good beta activity. But when you take a look at picture 4, you see there's a high rate of alpha activity, which is abnormal. You should see more alpha activity posteriorly, that is towards the back region of the brain, than you see in the frontal. Next slide, please. Beautiful. This is a functional imaging of children who are typical readers and children who are dyslexic. And as you can see on the picture on the right, you see this beautiful activity in the left hemisphere of the brain, particularly in Broca's region. You see in the frontal cortex, color-coded for you in red, beautiful imaging. And you see many areas of the brain fires when children are good readers. Not so for the child with dyslexia. You see, for an example, the child with dyslexia, we see hypoperfusion in the same brain regions, which means that the neuronal activity of these neurons are functioning at a very, very low level, and the child misses a lot. The only area that we see fire up in dyslexic children, and this is one particular case, you see that the only region that fires is the area in Broca's area, which is in the frontal lobe. Next slide, please. I took another picture. I think this paints a more better picture. It's pretty much the same one you saw previously. You can basically see for typical readers, the different areas of the brain that fires the child's reading, the inferior frontal gyrus, which is critical for comprehension, the superior temporal gyrus, which is good for integrating word information, and of course the fusiform gyrus, which is critical for letter recognition and face recognition. And with the dyslexic reader, you can see, for an example, that those areas, the same areas, are lightly shaded to show you an example of hypoperfusion, which means that there is low neuronal activity in the same regions of the brain. And this is this is basically a stamped profile of a child who is dyslexia. As you can see, it has nothing to do with parent involvement or teacher training. This is a neurological issue, and it must have neurological interventions to remediate that problem. Next slide, please. So we use the neurodevelopmental approach because, number one, we want to understand, first of all, that the brain development regarding brain structure is critical to understand what psychologists typically call mental health. And I teach a course in physiology, and the physiology of behavior, and I try to emphasize as much as I can that when we talk about mental health problems, we understand them to be neurological problems. And these neurological problems are related to abnormalities in brain structure or brain morphology that significantly impacts one's mental health. So we know, for an example, that brain injuries in children, particularly children who play sports and receive concussions, and these concussions accumulate over time, in the long run, these accumulated injuries can have a devastating effect on the child's neurological health or neurobehavioral health. We take a look at the nature and persistence of learning problems. If you look at learning problems independent of intact neurological systems in the brain, then the interventions that you're providing for the child may be inappropriate, and they may not, in fact, it may even frustrate the child because the child is not making progress. So we look at developing brain because the developing brain, of course, is very vulnerable to various genetic and environmental conditions that can later on develop into very severe disorders of childhood. These are some of the early studies, meaning that we've known these things for quite some time now. Next slide. So we pay attention to the scope and sequence of brain development, particularly cortical structures, and the cortical structures that correlate with behaviors. This is very important to the child's development and to provide the appropriate enrichment activities or instructional opportunities and interventions because they are brain related. So we look at many factors. We look at the interaction, as I said earlier, psychosocial, environmental, neurocognitive, because we want to really fully understand the relationship between physiology and psychology. Next slide. Some of these are repetitive. I'm going to skip over a few for the sake of time. You can go to the next slide. All right, so basically, when we look at the behavioral approach, we want to understand what are the behavioral factors that impact neuropsychological functioning. Well, we look at malnutrition. Poor nutrition has a devastating effect on the developing brain. We certainly look at the antenatal period and early stimulation that it has on the developing brain. We'd certainly take a look at the impact of the demands on the child. And what do you mean by demands of the child? Well, for an example, children will not manifest, depending upon the disorder, in the absence of, say, for an example, autism or Tourette syndrome or Down syndrome. Typically, children do not manifest these problems with attention. They sometimes manifest themselves early in preschool. For an example, a child whose behavioral trajectory and aggression is atypical for that particular child's age. But these are rare because what we want to know that sometimes the demands, like for an example, with reading or with writing, as the cognitive demands increase, then we begin to be aware that there are some problems. And this is why early intervention is so critical when children are in preschool programs, to be able to identify very early what these factors are so we can intervene early. Particularly interventions that facilitate the recovery after brain injury that could occur during labor and delivery, or brain injury that could occur later, which we call acquired brain injuries. Next slide. Okay, this is again just a repetitive of malnutrition and prenatal care. Okay, next slide, please. Early experience is important, of course, for brain development. Yes, because these experiences actually shape your brain. We refer to it as brain morphology. Racism and violence, when children are exposed to racism or violence, and these have a negative impact. I did a seminar a few years ago that looked at the impact of trauma, and I made a statement based upon the latest research that was given at that particular time, that children's brains can be damaged when they are not only victims of trauma, but you can damage a child's brain if the child is exposed to trauma as well. So we look at serotonin. Serotonin inhibits violent tendencies and has other functions that pertains to learning and otherwise. I don't have time to get into that, but maybe at another time, maybe we can deal with this. And then all aspects of consciousness are linked to, of course, neurons. All right, next slide, please. Okay, next slide. Some of these, as I said before, we looked at before. Just a word on COVID-19. I reviewed the literature on COVID-19 in the pediatric population, particularly learning problems. I really didn't see a lot there. So the next slide basically pertains to the adult population. Even though we do know now that the virus can affect the brain, we haven't seen it manifest in children pertaining to their learning problems as at this particular time. Although I have to say, I saw something in Science magazine. I couldn't find an article, but I think there was some latest research that shows that in the pediatric population, it could have some impact on memory systems. Again, I would have to check that out and bring that to you at another time. Okay, next slide, please. How does ongoing fear, COVID-19 relate to children? Well, fear responses and anxiety will affect memory. And that's one of the signs of brain injury, particularly if a child is exposed to stress. COVID-19 factors has caused a lot of families to experience undue stress, high levels of stress, and without ways to relieve stress. And so for children who experience high levels of it, you can say that's a form of trauma, and children can certainly have impaired cognitive systems. And I know the National Academy of Neuropsychology has put out a statement for neuropsychologists to, when we're examining children, by giving them a neuropsychological evaluation, to look at some of these, it could be research potential to see what impact, say for an example, the traumatic experience of COVID-19 can have on children's neurocognitive functioning. So I looked at some studies in the UK, and we looked at, again, this pertains particularly to the adult population. Can you go to the next slide, please? I'll just review these really quickly with you. And these are some of the neurological correlates of the 125 patients that they were studying. 62% had suffered some type of cerebral vascular accident. 74 was ischemic or hemorrhagic. These are pertain to vascular events in the brain. Other groups, 31% had altered mental status, and others, there was another subgroup they found had significant indicators of encephalitis and other types of unspecified encephalopathies. And about 59% had some type of neuropsychiatric disorders, and I'm sure the other presenter would provide more information about that. Next slide. And next slide, I'm just going to flip over these because I want to get to, next slide. Okay, this is the part I really want to get to. After all I've said, let me just sum it up this way. When do I see a neuropsychologist? Okay, you want to have a neuropsychological evaluation, particularly when screening of the child indicates that there could be some likelihood of a brain problem. But if there's knowledge that the child has experienced some type of brain injury or disease, and you want to understand the behavioral sequelae of that particular injury, you may want to have a full neuropsychological evaluation. Number two, you want to have a neuropsychological evaluation if you have any type of brain injury or disease that is highly suspect. In other words, you're thinking that there may be something going on with the child's brain, but you're not really sure. And you want to have, of course, a neurological evaluation. A comprehensive neuropsychological evaluation will certainly complement a neurological evaluation for better treatment intervention. Certainly a comprehensive diagnostics of the functional nature of the brain injury or disease that are necessary for rehabilitation purposes, and a neuropsychological evaluation will certainly be indicated in that particular instance. And then finally, neuropsychological evaluations are part of a complex diagnostic effort by psychiatrists, by general physicians, by neurologists, and neuroradiologists. And a comprehensive look at the child's profile, clinical profile, can definitely lead to better treatment planning and interventions for the child. Thank you so much. And I hope I didn't take up too much time.
No, you're fine. And thank you for your very interesting and on-time presentation. I'd like to start off with a couple of questions while Michelle looks at the chat box, and Dr. Neighbor-Stevens comes up with some questions as well. In layman's language, what is ADD and ADHD for one.
Thank you, Dr. Maxey. Okay, so when we say attention deficit disorder, ADD, typically is a disorder of the brainstem, where sustained attention is an issue. Children have difficulty with sustained attention, focusing for long periods of the time will tend to be impaired. And we find that the pontine nuclei seem to be impaired with children with that disorder. Now with ADD, it's critical that the clinician rule out whether or not it's truly attention deficit disorder or whether or not it's absence seizure, because in clinical profile, they look the same. A child with ADHD, attention deficit hyperactivity disorder, this is a disorder that's typically of the frontal cortex. And here we find children not only are motorically hyperactive, but they're also impulsive. They have difficulties with executive functioning, meaning difficulty with decision-making, complex thinking, problem solving seems to be impaired.
Okay, again, I'm going to go to Dr. Neighbor, Stevens, and Michelle, but I have a hypothesis that in order to be successful in life, you must have a degree of ADHD, which I think I have a severe case of that, even though I'm not a child. Michelle, do you have any questions in the chat box?
I do. Thank you. And so you did mention, I just heard you mention a little bit about executive functioning, but where does that fall? We don't hear that term a lot. We hear ADHD, ADD, but as far as executive functioning, where does that fall within the scope of neuropsychology?
Well, it's very critical. Executive functioning is one of the major theoretical components in neuropsychology, because executive functioning allows the individual to engage in higher order processing problems, and which is needed for complex problem solving. Unfortunately, many people think that intelligence tests, which are highly used by psychologists, it gives a good indication of the child's overall cognitive functioning, but it doesn't, because intelligence tests tend to measure posterior regions of the brain that's critical for problem solving with math or reading and so forth. But when you talk about executive functioning, which is primarily anterior, these are higher order processing skills that the child must have to in order to function adequately in the world. So problem solving, complex decision making, an individual who gets in trouble for the same thing over and over and over again has a poor executive functioning because he doesn't learn from previous experience, and that's what the prefrontal cortex does. It allows the individual to learn from prior experiences. It allows the individual to think at a higher level of abstraction in order to solve complex problems.
Okay, very good. Thank you.
I want to just push on that a little bit, because I think a lot of our community probably doesn't understand the longevity of the maturational process of the brain. In other words, in our country, we assume that 18, you're an adult. Legally, you are an adult. In some states, it's 21 that you can do certain things, like drink. But in fact, we have learned that it is the average human brain may not have a sustained full maturation by the age of 18, but we have societal expectations that this is an adult that we are dealing with. And I wanted Dr. V to talk about that just a bit. And then I'd also like for Dr. Stewart to pick up on that when she does her presentation, because it has awesome consequences in expectations and sometimes consequences that occur to our young people.
Well, adolescent brains look like adult brains, but they don't function like adult brains. And imaging studies have shown that adolescents tend to, there's more activity in the emotional brain, if you will, within the limbic system. There's more activity than there is activity in the frontal cortex. For an example, we take a look at the 14-year-old's brain and say an 18-year-old's brain or a 19-year-old brain, then it shifts, activity shifts from the limbic system to the frontal cortex where you see more activity. So even then it's still mature. I mean, your frontal cortex continues to develop well into your 40s, actually. So your degree of experience in life contributes to brain morphology that allows you to think more abstractly. Now, this is also critical to those around the individual. I mean, if you're not experiencing problem-solving activities, and this is one of the things I have with education, one of my major beefs with education is that children, it tends to be too didactic, and children are not involved much in problem-solving activities where they actually solve problems, learn to solve problems within their communities. And that's really critical, because in African societies, at least in my society, in my country, problem-solving was a major part of the survival of the community. So problem-solving was quite critical. In other words, we learned reading and math and so forth, but beyond that, we had to solve problems because that depended upon our survival. And I know the other presenter will probably touch more on that.
Well, thank you.
Wow, excellent.
Michelle, any other questions in the?
Certainly, Dr. Maxey. What do you consider a clean prenatal history? And do you believe that parents' negative effect during pregnancy can interfere with brain development of the baby?
No doubt, no doubt. And when I say clean, typically clean means good prenatal history, good nutrition for mom, healthy attitudes on mom and dad's part. And dad has to also have a clean history too. I mean, if he's abusing himself with alcohol or other chemicals, that can have a negative effect on the child as well. So clean in this particular case, meaning an overall good prenatal history, good family history. For an example, if a child with, and the jury isn't out on this yet pertaining to attention deficit disorder, because attention deficit disorder tends to be idiopathic, meaning that we don't know the cause of it. However, in an absence of either parent of having attention deficit disorder would be another example of a clean profile where mother or father hasn't the disorder, or a near relative hasn't had it and the child has it. It's pretty much the same as a child who is left-handed and is having difficulties in school, and you do a clinical profile of mom and dad. And if mom and dad are both right-handed and the child is left-handed and having learning problems, then we know that the brain has been damaged during development, because right-handed individuals, the language centers for right-handed individuals is housed in the left hemisphere. And even though less than 5% of people are naturally left-handed, there is a significant number within that group who are left-handed by reason of brain injury.
I'm going to push on that a little bit because I'm left-handed, but that's not the question.
I was going to say that. I knew you were going to say that. Somebody get that all the time.
but there's a point I want to pick up on that most of us, I hadn't thought of. I know the mother's prenatal health is very important, but tell me how the male's prenatal health can affect the sperm. I'm presuming that's what you're saying. And many of our young men are into abuse of their bodies, whether it be drugs, alcohol, stress, or whatnot. So that does play a role.
Yeah, you can have.
So that's very significant, because most of us think we can do everything we want to. It's up to the woman to be pure.
Well, Dr. Maxey, I'm so happy that you pushed that point. That's a very significant statement, and the health of men, the fathers, are critical as well. And we tend to, it reminds me of when autism was the early understanding of autism initially was that it was a mother's problem. Early researchers believed that autism was the result of a mother-child bond. And mothers were blamed for quite some time for being the cause of the child's autism. And we now know that that's no longer the case. We know now that autism is a neurological disorder. Well, for a long time, when children were having learning problems or different types of issues, the mothers was typically blamed for the problem. Research, and even when I studied at NIH, the National Institutes of Health, and when I was there when they were doing the Genome Project, and the jury was already out pertaining to health of men, health of fathers. If men abuse their bodies with alcohol or drugs, or if they just have a very bad attitude, if they're very stressed out, that can certainly impact the sperm, and it can have a negative impact on that developing embryo, no doubt about it. So the
I
health of
propose
fathers
that,
are also
I
important.
propose that we do a study on some of our gang members' children, not only because of what they use, but because of the stressful nature of what they do. Let me move the program on. Thank you so much for your very astute presentation. We're going to have a lot more questions. I'd like to introduce the chairman of our advisory group, Mr. Carl Brooks, for a word.
Good afternoon. We are in the midst of a very, very difficult period within the United States. We are losing respect among peer countries, not only because of the way in which we performed relative to the coronavirus, but just the series of violent issues that are happening all across the country. Our leadership is being questioned, and we need more than ever before everybody to get out there and vote like your life depends on it, because it really does. It's interesting as we watch, we're still struggling with PPE and ventilators and not enough capacity in hospitals. This is 8 months after being aware that we had a problem. We're struggling, and other countries are asking United States citizens not to travel there. Not only Europe and Canada and our neighbors, but we're having problems even traveling to the Caribbean islands. They're asking Americans and Europeans not to travel there because they don't want our virus. If you've ever voted, now is the time for you to get off your butt and go out and vote. If you don't do it for yourself, do it for your children or your grandchildren. These are very, very, very important times, and we got to show some evidence that we care, and we show our caring by voting. You don't only vote for the vice president and the president, you vote for mayors and governors and other legislators and others that can affect your quality of life. Please vote. On a second nature, I wanted to bring you up to speed on something that's happened. Randall mentioned that in my former life, I was president and CEO of the Executive Leadership Council. For those that don't know, the Executive Leadership Council, as I refer to it, were the baddest brothers and sisters in corporate America. And they were. They were the highest ranking brothers and sisters, and they still are. On Thursday of last week, I attended the virtual 35th anniversary for ELC. The group is continuing to grow and thrive and has expanded to include executives, Black executives, entrepreneurs. That's a reasonable choice to expand to include not only corporate people, but executives from other areas. But what I've watched with great joy is how they've gotten the kind of sponsorship and support from not only the member companies, but from other companies that see the benefit of supporting our community. Randall has done a fabulous job of bringing together the baddest brothers and sister doctors on the planet. There's no doubt about that, but we can't do it alone. These programs have been running since June, and without any financial support, and we've been working on a shoestring to make it happen. We can't keep the quality up, and we can't continue to do this unless we get support from you. As I said, ELC members are the baddest brothers and sisters on the corporate world. These are the baddest brothers and sisters in the medical world, and we need to support them. We need your donations, and please look up blackhealthtrust.org on our website, and please support us. I'm not in the habit of knowing how to beg, but I'm asking for your help. We need your help in order to keep these programs on every Sunday and giving you the best and brightest information that we can provide. Thank you very much.
Thank you very much, Dr. Brooks. Your passion and your work with us has been legendary, and we certainly appreciate you, and I say thank you for being married for almost 50 years. And I'm
We see where that Barry White voice got him.
Okay. I'm going to introduce Dr. Neighbor Stevens, who's a graduate of medical school at Tufts University in Boston. But before I do, I got sent an article, and it was saying that Black newborns die more when the physician involved is not Black. We know that there's a certain amount of clinical competency, but also cultural competency that is needed. And we here say we enjoy the greatest country on earth, but our statistics of child and infant mortality, maternal mortality are among the worst in the world. So Dr. Neighbor Stevens has been on my case for weeks and weeks to bring doctors who specialize in that. And we here at the Black Health Trust want to bring you the best of the best in mostly minority doctors, not all minority doctors, but doctors that have experience with communities of color. Dr. Neighbor Stevens and I both represent the National Medical Association, which was created in 1895 when the American Medical Association would not permit physicians of color to join that. So we've been in business since that time representing physicians of color in communities of color, and we represent more than 30,000+ physicians across the United States. And we've had many of our past presidents, chairs of boards, section heads making these presentations. So this is a very serious endeavor to give information that can help make our communities much more safe than they are. We have had a lot of information coming from companies that want to do business with us. We're working with our lawyers to create the appropriate contracts, because many people on these calls have expressed that they don't have confidence in the medical system as currently constituted, that there is inbuilt structural racism, there is inbuilt discrimination, inbuilt lack of cultural competence of taking care of our people. So we're trying to assemble panels and groups of experts to give second opinions and first opinions, as well as cost-saving measures, all given by people that share values about protecting the health and wealth of our community, and we will be doing that. But Dr. Neighbor Stevens, if you would kindly introduce our next distinguished guest, I'd appreciate it.
Thank you so much, Dr. Maxey. So after that very stimulating presentation by Dr. Vi, and I know that there are a lot of questions being germinated from some of the things that he said, hold tight, because you're getting ready to go even further down this path with our next speaker, Dr. Stewart. Now, Dr. Stewart has dedicated her life to improving the outcomes of our children. And I know that her heart is and soul is in this endeavor. And it was why I really wanted to get her on this program, because all of us are very concerned about our children and our families. And she knows that through history, we have had these kinds of issues, and is able to give us some insight into how to go forward with our very difficult circumstances. So without further ado, Dr. Stewart.
Well, good afternoon, everyone, and thank you for that warm welcome, Dr. Neighbor Stevens, and to you also, Dr. Maxey, for the invitation to join this distinguished program today. I want to certainly thank my colleague who preceded me for laying a wonderful foundation on the science and the biology and the neurology and all of that, so that I can fly through all of that, because I think you've gotten a lecture today, folks, that is the equivalent of some of the lectures that we get in school about how the brain operates and what it means when it doesn't function well. It was, I will tell you, Dr. V, it was like a walk down memory lane of hearing some of the underlying science that I use every day to help people understand how the children that I work with wind up out of their homes, out of their communities, in these placements, whether it's juvenile justice or child welfare or something that removes them from their home and community and puts them into settings where not only is their brain not fully developed enough to understand what all is going on and what it all means, but they are not fully equipped emotionally, psychologically, and clearly physically and neurologically to adapt to understanding and behaving in a way that accelerates their departure from those systems. And so I thought you were gonna say, Dr. Neighbor Stevens, that I was gonna take us further down the rabbit hole. So I'm glad you didn't say that. But I would like to shift the perspective a bit to give people an opportunity to close their eyes and think about what I'm describing in the context of a child that you know, or your own child, someone else's child in the family, some child in the neighborhood, some child you've seen at church, where the struggle is manifested. The way we see it is a behavior. The children I work with tend not to have gone the route that Dr. V describes, because people don't pick up on the brain disorder and study that. They pick up on the behavior and punish for that. And so I'm gonna shift gears just a little bit. And if I could have the my slides, please. And so what I'm going to talk about, as you see on this title slide, has to do with my ongoing aspirational hope that we can figure out how to use that great science that you just heard about to create better systems, better programs, better policies, become better advocates, and really do, as Dr. V said, teach each other how to think about these things critically, so that we can approach the people who we are voting for, make sure that they understand what we need for them to do is to understand there is science to support what the two of us are talking about with you today. So I'm gonna frame my comments today in under the umbrella of adverse childhood experiences. These are those events, experiences, activities, and unfortunate things that happen in the life of a developing child that stay with them psychologically, physically, emotionally throughout the rest of their life if we don't make the appropriate intervention, and if we don't create an environment around them, literally wrapped around them, that gives them a reason to be hopeful and helps them become more resilient, thereby helping our communities become more resilient. It is our caring about the children that generally leads us to trying to do better, to be better, to seek out better. And so when we begin to understand, and that's part of my task today, to help people who may not be able to make that connection between what Dr. Villa was talking about and what I'm going to share with you, so that you can use this practically in your home community, within your home itself, and in your families. Next slide, please. Okay, the typical way that adverse childhood experiences are described is through this pyramid. And I'm not going to go into great detail because I know we want to have plenty of time for some exchange. But this is the typical understanding of what adverse childhood experiences are and what they mean. something happens in the life of a child, in that developing child whose brain you saw on Dr. V's slides, who you heard have these challenges at various developmental points around how they understand the world around them, how they interact with that world, if there are specific brain problems and diseases, what that means. We think of adverse childhood experiences in three different critical ways. One is children who are abused are considered to have been experiencing adverse childhood experiences. And abuse can be physical, emotional, or sexual. It's sort of the big picture abuse, not a specific incident, but the fact that the abuse occurs. The other area where this becomes important to understand is childhood neglect. When I talk about neglect as a psychiatrist, I'm talking about anything that creates an environment where that child winds up feeling uncared for, unloved, and if there is abuse, that will not end. Where children who grow up in communities where they're always told they won't ever be anything, they won't amount to anything, you're just like your daddy and he wasn't nothing. These are the kinds of environments where childhood maltreatment and neglect occur. And then the third area where we look at adverse child experiences has to do with the environment in which the child grows up in, who's in the home, who's not in the home, the reason that people are in the home. Have they died? Are they physically or mentally ill? Are they incarcerated? Does the child have any stability in terms of where they live? Or are they moving from place to place because of what we now call in social services, housing instability? Do they get food and nourishment that they need on a regular basis? Are they kept clean and clothed? And is there someone who on a regular basis says something supportive, positive, and loving to them? And when any or all of those things are missing, it's a very basic questionnaire. It's got 10 questions. You answer yes or no, but it's about the child under the age of 18 growing up. It is generally something that we look at from the adult perspective because we're asking people to look back, but we're getting much more sophisticated. And so there are now questionnaires and surveys and tools that are being used in pediatricians' offices, in the primary care clinic, in after school programs to begin to identify these things as they are occurring so we can get out ahead of that. You've all heard the story of the community where the people found babies floating down the river and they spent time scooping them out of the river. So someone said, let's go upstream and see how they're getting in the water in the first place. Adverse childhood experiences require that we be prepared to go upstream. Because once that happens, there's some very clear events that occur in the life of that developing child. Some of these things happen very early, like prenatally and 0 to 3, before the child is even exposed to the school environment. Some happen then, but continue to happen and maybe get more intense as the child grows. And so you've got this whole host of social, emotional, and cognitive just means thinking stuff. What Dr. V described as that part of the brain where you put together things and make decisions. Sometimes with too many of these adverse childhood experiences, not only does your brain not properly develop, but it develops in a way that the wiring, if you think of the brain as a big old electrical circuit, the circuit breaker in a child's brain who's been exposed to ACEs, adverse childhood experiences, it's like the circuit breaker has flipped. And until you can figure out what it's going to take to go in and flip it back so that the circuits are alive and effective again, and depending on how long and how able you are to control some of the things that are leading to that, that child's brain can be irreversibly wired in the wrong way. And these other things then begin to happen. A child who's been impacted by ACEs and has these kinds of difficulties that start to get baked into their brain, they begin to do things that are risky because their brain doesn't tell them that's risky. The brain says, looks like fun to me. Let's do it. And when you pair that to the fact that you've got a child whose brain has been affected, to the fact that our brain, as you heard from the last session, doesn't really fully mature until well into our 50s, is when we think we're getting along the road to having a pretty good brain. Just think back on your own childhood and the things that you did then that you are so glad there were adults around to tell you, no, you can't do that. And think about your own children, if you have them. And how many times do you have to tell a child of a certain age to stop picking on their brother or sister, to clean up their room, to take out the trash before it takes? If there are issues in that child's life that would represent adverse childhood experiences, it's likely that you're going to have those challenges in a big way because their brain isn't functioning well. And then after they start doing these risky behaviors, then you get into this whole host of other things. A risky behavior leads to some other disorder or disease. If the risky behavior is drugs, alcohol, cigarette smoking, sexual promiscuity, pregnancy, those are the kinds of things that lead to maybe disease, maybe disability. A kid whose brain isn't functioning well, who's doing risky things, is more likely and vulnerable to being recruited into things where they can take lethal proportions, like getting involved in gangs, becoming a bully, having a lot of fights, getting kicked out of school, those kinds of things. And what we know through the science again is that those are the children where early death becomes a part, either lifelong disability or early death can become a part of their lives. And that's one of the things we wanna try to present by understanding ACEs better. Next slide, please. And so I want to just describe, and you ask yourself, I know something like this. The traumatized child, the child who's been exposed to a lot of adverse childhood experiences, sees the world, the outside world that they exist in, as punitive, judgmental. It's built to humiliate and blame them for everything that happens. It's the outside world that controls them. And so they have no concept that they can regulate these behaviors, that they can learn ways to stop this acting out as we describe it. These are kids who don't trust anybody. Other than the ones they hang out with, everybody else is suspect. They keep making the same mistakes over and over. And the one thing they are very clear about is that you never admit that you made the mistake. You just don't do it. It's always someone else's problem. It's always someone else's fault. It's the society you live in. It's the man. It's whatever makes the most sense, but not that you made a mistake. They are hyper. I mean, they are on edge, expecting the next attack, expecting the next assault on them, expecting things to go wrong because that's been the story of their lives. They're very emotional and reactive. They can hold on to a grievance longer than most adults and can tell you chapter and verse why they don't like somebody and relate it back to early experiences and exposures and interactions. These are the children, when they get upset, it is very hard to calm them down. They don't regulate themselves and they cannot really understand how you are trying to help them regulate. And finally, they don't take responsibility for the behavior. It's not that they don't understand that they did it, they just aren't responsible for having done it. Next slide. And so that get upstream and figure out what was going on reflects an approach that we are taking now for these children to try to redirect them systems and back into communities and environments where they are surrounded by their village, if you will, is based on an approach that we simply call trauma-informed care. It is based on the strength and not the deficiency. Every child that I encounter has some strength. We sometimes have to look very deep to find it because they're pretty good at covering up what they're good at, because typically it's been directed into some delinquent or activity. But the child who is, for example, the child who is the lookout and can quote prices of the drugs in their community has some pretty savvy math skills. We have to figure out how to redirect that. Once we've got their attention, we've got to figure out how to redirect that into a more legal entrepreneurial outlook, and help them see that as a strength that can be used for their good, as opposed to being on the path to delinquent behavior and the criminal justice system in adulthood. We have to figure out how to recreate around children what the some of the people who do this work call create that village. The most important thing in the lives of any of these children is a consistent, caring adult presence. It doesn't have to be a family member. It doesn't have to be a parent. What it needs to be is an adult who's not going to give up on them every time a mistake is made. The adult who's going to remind them that they have strength, that they have something to offer, that they have something good that they can use to make their lives better, and who's going to accept them and the fact that they're going to make mistakes, but not ridicule them, punish them, or abandon them every time they make a mistake. And that the skills building is related in two ways: that we want our children to be educated because that really is the basis for them learning and becoming competent in some of the skill that they need. But we also want it because we want them to become empowered. Children can be their best advocates once they understand what their need is. They're very good at telling their story. They understand how to, and I use this word in a guarded sense, they understand how to manipulate the narrative so that the story is so compelling that we want to do whatever it is, whatever we need to do to help them have a better life. Children are very good at that. Most of you who have children know they can spin a good story and tug at your heartstrings and get you to do stuff that you said you weren't going to do. And then you realize, I said I wasn't going to do that, and they got me again. So we just need to help them direct that in a more positive way. We have to create systems of care where families are involved, not just the child that we are working with. It is that child in the context of their family. And in the Black community, family is very loosely defined. Family can be everything from blood kin to the people that know us best, the people in our church family, the people in the neighborhood. I grew up in a neighborhood in the South where there was one lady who took care of all the kids in the neighborhood from the time they were old enough to go somewhere to be taken care of. We didn't have daycare. And Mama Donnie was what we called her. Mama Donnie knew everybody's business. She knew every child. She knew what every child needed. And she parents understand what that was without putting them down. We need to create and recreate those systems around our children and families. And we need to stop talking about parent training because that's not what we do. We don't train parents, we encourage them, we support them, we model things for them that will be helpful, and then we explain why we think it's helpful and encourage them to try those things. If somebody told me I needed parent training, I'd tell them goodbye because we don't demand that people get a license to have a child, but once they have a child and there's a problem, they got to go for remedial training. It's all in how we say it, I think. We use this, what I called the wraparound approach, which is a little bit of mental health for those kids who have serious brain disease and brain disorders. We do a lot of trauma work, and then we do a lot of community support and family support so that parents and children and families and communities can take these things themselves and not become dependent on us for the solution to their needs. And then, as I said earlier, we work from a needs base and a strengths base and not a deficit base. And we establish all along the way with the family and the child ways for them to create what is the goal for you. For many of the families that I work with, the mom, and it's many female-headed households, the mom is, I don't want to have to take off work again and go down to juvenile court. It's that simple. And so we work with her on crafting her plan so that her child understands the behaviors that they need to begin to demonstrate so that they aren't identified at school by the school resource officer who then calls the police, who transport to the juvenile court where mom has to come and pick them up if they're not going to be detained. Next slide. And so what it does, what trauma-informed care does, it makes everybody rethink the traditional way we have worked with children who have these kinds of, and whether it's a child with a brain disorder, been exposed to some physical trauma like a sports injury or an automobile accident, or been brutally assaulted in the home or in the community, or whether it's a child who has witnessed violence and is reacting to that based on the trauma they've been exposed to, or whether it's a child who's been, uprooted from home and family through death and housing instability and loss of jobs or illness in a caregiver or whatever it is. Everybody in the system has to begin looking at this differently and factoring in some of the things that Dr. V was talking about. Are we looking at a child who needs more and more intensive clinical study so that we can make the appropriate decision about what the next step is? Are we looking at a child who has just been so immersed in the violence and the issues surrounding them and their environment that we've got to take a step back and figure out how best to approach supporting that family and that child to help them figure out what their needs are and how to best meet those needs. We've got to, everybody needs to be comfortable with this. And one of the challenges for the medical community has been what I'm talking about says we partner with families. This is not, I bring my child into the pediatrician's office, they tell me what needs to be done, I go home and I do it, and the child isn't better. What's wrong with you people? This is where we really do have to form partnerships. And I do need to correct one thing. I'm not a child psychiatrist. I am a psychiatrist who spent the better part of the last 20 or 25 years working in systems for children as an administrator who's had to learn the way we work best with children and families has to do with how we partner with them, how we help them become comfortable with what we're doing in support of them. And most importantly, my job has become how to help my medical and professional colleagues understand we ain't the be all end all knowledge of everything. That many parents were dealing with things, many communities were dealing with things before we brought in our great and sophisticated and effective programs. But that we have to believe that they have an understanding too. I had one mother tell me, Dr. Stewart, y'all may be PhDs, y'all are real professional. I really like what y'all are doing, but I'm a PhD in this child. So there's some things I know about this child that y'all will never understand. And we had to acknowledge as a team that that mom was absolutely right and back up and let her guide us in some of the things that were challenging to her and her child. And we have to remember at the end of the day, when we're talking about these children, it is not what is wrong with them. These are not bad kids. It is what has happened to them 99% of the time. And we got to keep the uppermost part of our minds. Next slide, which should be, I think, my last one. And I use this to kind of bring things home because of a dear friend of mine, Dr. Carl Bell, used this a lot in presentations. So I lifted this from him to remind people that we all know children who are at risk for something. In my case, it's children who are at risk for going outside of their home, outside of their community, into some confinement setting. But these risk factors don't have to predict their future because all of us serve as the protective factor in the life of some child. We have got to create how to weave that into a fabric that surrounds them until their brain catches up, until society understands that just because he's a big Black boy who is said to be 16, who's really 14 or 13, he just looks big and behaves like he thinks he's an adult and may even give out adult vibes in his demeanor, that in fact he has an undeveloped brain. He does not know how to make good decisions. And so, coached by an authority like a school resource officer or like law enforcement, he's going to do what that undeveloped brain tells him, which is, you can't tell me what to do. I can do what I want to. You don't have any reason to stop me. And therein becomes the problem that many of our young people, especially our young Black men, run into in the environment of school and community when they clash, when their underdeveloped self clashes with an overdeveloped authority system. They never win. So we've got to help around them the things that they need to help them get past that age and hopefully their brains are fully developed. I think if there's one more slide, I think it should be the absolute last one. Yes. And this is just my contact information. Since I know that the slides will be available for people who want more information on any of the things that I've said today. So thank you for your attention, and I'm happy to take questions if there are questions.
Dr. Stewart, thank you. That was magnificent. You know, I'm what's known as a blood and guts physician. This, though, has been an awakening for me in the area of mental health and psychological. And as you were talking, I said, we need an emergency consultation at 1600 Pennsylvania Avenue. Because that brother has undergone ACEs, and he is definitely in need of help. And I don't know who I'm talking about, okay? But in terms of questions, while Michelle looks at our question box and Dr. Neighbor Stevens, I was brought up in a time when I had no fear of my community, but I had fear of my father and mother. And by today's standards, some of that would be considered child abuse. But I had no issue with police because I was more scared of my daddy. What is your comment on the so-called old way of discipline of our children versus this new way of just talking to them?
Well, you're absolutely right. Many of us came up in that time where I would walk on broken glass rather than have my mama have to be called to the school for anything. And so that fear kept me in line, even if I thought I wanted to do something. I think part of the challenge for us is that as our generations began to see openings, we lightened up a little bit on the look. You know, your mama could look at you and that was enough. The look lost its power because the generation of people who didn't have the struggle, the generation of people, because the parents weren't forcing those kinds of things. I mean, that was how we were raised. You understood coming out of the womb, there were ways of behaving, and then there were ways to get the look. And then if the look didn't help, there were other things that could be brought to bear. Everything from go get your own switch because you're going to get a whipping, to the shoe or the extension cord. And by today's standards, you're right, that would be child abuse. There is something though in the middle, I think. And what I'm talking about is that period where developmentally children can learn what's okay and what's not. It can be a challenge because we really want this, I want my child to feel independent and stuff. But what we are learning today is that independent thinking and behavior comes at a price for many of our young people because they don't have boundaries, limitations, and an understanding of how the world around them reacts to them. That 14-year-old who's as big as a 16-year-old doesn't get the fact, because his brain is not developed. He doesn't get that to the outside world, he's a big and threatening picture of a Black man. And that generates a lot of things. We forgot to teach a little history. We forgot to use the lessons anecdotally even of why we say and do certain things. And we allowed ourselves to be lulled into thinking that everything was fine because integration took care of the education piece. Movement up into corporate America took care of the employment piece, and everything else kind of was going to settle in. And we allowed ourselves to get lulled into thinking that we didn't have to continue having those conversations beyond the conversation we have about driving and other stuff, that there was a broader conversation that had been a part of growing up in a Black community where you had to understand certain things that meshed with your growth, with your development, with your understanding of the world around you. And it has resulted in many of our children challenge. The rate of suicide in Black youth has increased hundreds of percent over this last decade, 5 years actually. The number of children who are now detained for what are clear behavioral issues that we should be offering treatment for, who are being captured because no one in the court systems wanted to understand that there was a science behind the behavior. That heinous act, and this is not to excuse the behavior, that heinous act was done by someone who does not have a fully functioning brain. So expecting them to behave like an adult and understand the consequences as an adult should, it's just unrealistic and unreasonable. I work with children who are 13 and 14 when they commit those acts, who are still stuck developmentally at 13 because nothing that has happened to them since then has allowed them to grow and develop and appreciate the seriousness of their act. Little boys who have to roll up the bottoms of their jumpsuits in juvenile detention because they don't make them in their size, whose feet don't fit the slippers that they have to wear. These are children, and calling them juveniles conjures up this image of criminal and predator, and that's not my child. And so a lot of it has to do with what we talk about with our children and how we talk about it. A lot of it has to do with our own levels of comfort with appreciating that our work is not done. We have not come so far, in the words of Brian Stevenson, the lawyer who wrote Just Mercy. We have not come so far that we can afford to be away from problems like this. We have got to stay close, what he calls proximate to these problems, if we're going to really help our children not be, summarily disabled and destroyed because of our lack of ability as adults to inform them, to help them, to
I think, is Dr. Stewart frozen on your screen as well?
Yes.
Okay.
Let's go to Dr. Stevens.
Battle them if we have to.
There she
Social
is.
media. Okay,
Oh, there
I'm
she is.
sorry. Sometimes when I get animated, I touch things and I shouldn't. So I apologize if I froze up on you guys. All I was saying is social media cannot be the guardian for our children. We have got to get involved. We don't know if our children are cyber bullies because we don't know what they're doing online. We give them the phone, but we don't manage it. And there is no reason other than for emergency contact that any child should not have, you should not have access to anything on your child's phone, and that you shouldn't educate yourself about these, I don't know what they call them now. The kids told me the name, but I don't remember it. Some kind of shadow app that runs in the background that they can access and have their little private conversations on. We need to educate ourselves as adults and parents and caregivers about all of this stuff. And not say, well, I'm too old to learn, because that's how they're influencing each other. And that's how some of these issues are happening.
Excellent. Dr. Neighbor-Stevens?
I almost don't know where to start, but let me just bring it to the a very current event. Let's say you're having family dinner, well, maybe you shouldn't have the TV on while you have family dinner, but you have everyone sitting around the table and you have the TV on news, and the whole George Floyd situation is shown, or any of the other multiple incidents that have occurred recently. It's not new, but increasingly so. Many of the communities are still having protests, some of which are violent. Definitely the setup is one of fear, with police with all their equipment on surrounding citizens. How are we to, you said, you quoted Stevenson, we have to be proximate. How are we going to help our children understand that, first of all, it's not necessarily all wrong or all right, but understand that they have to understand what is going on to the best of their ability. We need to help them understand what's going on and help them figure out a strategy for coping with what we're living with.
Well, that's a great question, and it opens the door to talk about things in stages. Early on in childhood, we have to begin to figure out what's appropriate for this age in my house. What's my belief system? What's my cultural reference to all things? And in many families, because of some of us who grew up at times when extended family was a part of the whole solution for things, so that kids weren't left to their own devices or being raised by devices or television or other stuff. So since we've lost that, we've got to figure out how to recreate that. Sometimes we do it in our own homes. Sometimes we do it as groups of people whose children naturally have an affinity with each other. However it's constructed for your child, whether it's just your family or outside people that influence your family. My recommendation is age appropriate to start. That with younger children, you talk about what bothers them, how they see these things that they're hearing about or seeing on television. Are they understanding in their own way? Are they understanding the connection between what they're hearing about, say in the George Floyd murder, the protests that followed that I thought of as a teachable moment. There were people who were so upset about the fact that this had happened that they took to the streets to say, we've got to do something to not let it happen again. How does a 5-year-old or a 3-year-old understand what that means? And that's something that you've got to, in a relational way, understand with your child and help them appreciate what it all means. In many homes where many of the children that I work with, relationships are transactional. Child wants something, I give it to them, we barter for behavior. That has become much too important and happening too often, because now the relationship between me and my child is, if I want them to do something, I got to give them something. Well, I'm not opposed to giving and making children comfortable and offering them some of the pleasantries of life. But when the child begins to realize it's a transaction, they will continue the transaction, and you got to up the ante every time.
We train animals, give them a piece of carrot and sugar.
Pavlov made history with that. And that's really not what we want with our children. Dr. V said it so well earlier. We want them, if they're not going to learn it in school, we want to help them become critical thinkers and problem solvers. We want them to look at something and say, well, if I was doing it, I would do it this way because, and then we want to have a dialogue with them about their way, our way. How does each, have some consequence or not? As children mature in age, we ramp up the conversation because now they're engaged in the society around them. They're seeking independence. They're looking for ways to distinguish themselves from a part of the family. For me, it was being the baby in the family and always being somebody's little sister. And I began to resent that. and children begin to resent things that they don't understand and don't fully appreciate. And so we have to help them through conversation again. You know, this notion that we can't talk to our children except to tell them what to do, we've got to really reframe our relationships with our children. If we want them to survive, and I mean, not just be alive, but to survive and thrive into adulthood and productive life, we really do have to help them. That means that society will allow the transaction, but look at the number of people who thought that who are no longer employed, who don't have, you know, the resources to support themselves, much less their children and families, and who are struggling right now. And of course, all of this means that as adults, we have to do good self-care for our own psychological well-being. We can't sit around depressed and expect our children not to sense that and feel that and mirror and model that. As the child gets into adolescence, we want to talk about independence, responsibility, and where accountability rests. Where does accountability live in my home? Children say, it wasn't me, I didn't do it, all the time. Somebody broke the lamp. Somebody drove the car and got the dent in it. Somebody took the lawnmower over a rock and broke the blade. Somebody did that. How do you handle accountability in your home? Sets the stage for how children learn, I am responsible for some things, I am accountable for other things. And the bottom line is, I have a role to play in what happens in my world. And it's not just all external to me. Remember, the picture of the traumatized child is, I got no control. I can't regulate none. I don't have any responsibility. It's all on y'all. We have to reverse that.
You know, you just said so many things that all of us, I'm sure, and I really am fighting, I'm imposing discipline on myself not to push on some things that you've already said, but there's something that I really want both of you to comment on, because I actually feel very strongly about this. And I think there's another example of misinformation being disseminated. And that's this whole thing about children must go to school and that it's damaging if children do not go to school. Outside, I'm not talking about the issue of the, and maybe I should, but the issue of not receiving the educational information because they don't have internet. I'm not talking about that. I'm talking about this stuff that people are trying to push, that they need to be together in a schoolroom. They need socialization. Mm-hmm. My personal bias is that the first school is at home. Mm-hmm. And if they have to stay home and look at the computer to learn, as long as the quality of the information is good, that should not be a source of damage. It may be inconvenient, but it's not a source of damage. And if both of you could comment on this whole question of the children have to be back in school.
Well, I'm not a big believer in the children have to be back in school. I fully support the concept that children learn valuable life lessons through socialization with each other. Everything from being competitive without being overwhelmingly abusive and pressured in the area of competitiveness, to how to have positive social interactions and disagree without the assaults and the aggressive behavior and the bullying and everything else. I don't think that has to happen in school. I think there are creative ways, and as adults, we ought to be a little more creative than thinking one size fits all. Because school is not really the ideal place for children to learn good social skills. The way schools are constructed today, it is not a given that sending your child to school is going to give them the social, emotional learning that they need. The school will try, but there are so many other things that impact that environment. I think we are much more creative as humans than to think that unless my child is in a classroom 6 hours a day, then they're going to miss some valuable social lesson. I don't buy that. And I think we can construct other ways, especially during the height of the pandemic. I think we can construct other ways for children to learn valuable social skills and translate that into social behaviors that will not take them off the path to positive, productive outcomes. I think we are capable of doing that. And there's some very great strategies programmatically that allow that to happen. But I want Dr. V to weigh in too.
Well, it's a very interesting question. My brain was just, there's a frenzy of activity in my brain right now to deal with that question. Well, number one, the question, children need to be in school, that has really already been addressed. I think about maybe 10 years ago when that question was raised about, do children need schooling? And the answer to that question scientifically was no, children do not need schooling. Children need to be educated, but they don't need to be, but schooling is not required. Now, I find that interesting as well. Who is saying children need schooling? Well, let's take a look at the African-American population. If it's, and it has been said and it continues to be said that African-American children continue to lag behind their white counterparts. If that's the case, then schooling has not worked for Black children. Schooling has not worked for Black children. If Black children continue to lag behind their white counterparts in terms of academic progress and so forth, and we have the data that they have not, then obviously schooling has not worked. I favor more educating our children than schooling our children. Because education deals with helping children to develop plans of action in the African communities. And in my community, for an example, I'll go back again, we had two different societies. One, we had the Poro Society, that's P-O-R-O Society, and we had the Sante Society, that's S-A-N-T-E. The difference between the two is in our culture, boys and girls were educated separately, not based upon discrimination. Sierra Leone is a matriarchal society. Now, when boys went to school to learn, they not only learned the fundamentals of arithmetic and math and reading, but they also learned culturally, passing down from one generation to the next generation, how do we survive as a people? Boys and girls had learned how to get along. So, and for an example, marriage in my country before the Europeans came was non-existent. There was no divorce in my country prior to the Europeans. Survival in our community meant, educated in our community meant that we had to learn the tools, the cultural tools, which enabled us to survive. In this country, unfortunately, we do not have a system. For some reason or the other, we weren't satisfied with segregation. And when we're educating our children, we still develop physicians and scientists and teachers and so forth. We didn't have a problem with that. It seemed that somebody believed that we had a problem with being educated separately. Now, if you take a look at the system of racism in this country, if you take a look at the system of racism being an unjust system, then I would side with you by saying, okay, fine, well, let's take a look at how white children are educated. Let's take a look at how Black children are educated. And within the same parameter, let's take a look at the qualitative differences that we knew, or the cultural differences that we knew that we had to instill upon our children. Discipline was number one. You know, you don't talk back to your parents. You don't, in fact, in my neighborhood, you didn't talk back to your neighbors. You came home with that situation. So, I mean, I don't know, this thing about children being schooled. Of course, children need socialization. Well, where do they get socialization from? They get it from their family. They get it from their community members. I don't know if they need to go to a classroom to get that, because children will get that automatically. We know, for an example, that I was reading one research about children and learning, for an example, in reading or math. can a child learn to do math, or can a child learn to read without being in a classroom? Fundamentally, we know a child does not need a classroom to, for an example, to learn math. A child does not need a classroom to learn how to read. They did a study in Brazil with they have a large population of children who, because of poverty and other situations, never went to school. And what these researchers found, that these children still had the ability to do math and reading, even though they never stepped foot in a classroom. So your brain, we know about the brain is wired for reading. The brain is wired for math. Infants as young as 6 months old can do math. As young as 6 months old. So I push for, let's educate our children, because children don't necessarily need schooling. I know I said a mouthful, but that's another discussion altogether when we deal with this issue about who are the ones who are saying that our children need certain things. And the question is, well, where's the science behind it? If our children need schooling, where is the science? Show me the evidence. I tell our students all the time, these are upperclassmen, these are pre-med students, science majors in biology and so forth. And I said, okay, fine. And at the university level, as you progress year to year to year, especially during your junior and senior year, you should become less opinionated when questions are posed to you. When you speak from a body of evidence, then you're better able to educate others. So if someone is saying our children need schooling, then the question is, well, show me the evidence that they need that.
Doctor, I have a question I'd like to ask, and we're approaching the time when we are going to need to close out. But we have a medical advisory, and we have been discussing the pros and cons of the coming vaccine, the current flu vaccines, and at some point, possibly a vaccine for COVID. And one of the lingering questions that has been placed on our plate is, do vaccines or their content have to do with increasing the degree of autism? What about other heavy metal and toxins? And even the more conspiracy theory things, do they want to implant control mechanisms in us? Would you comment on some of the evidence you may know about developmental disorders related to vaccines?
Dr. Maxey, there's been some indication that certain vaccines can lead to autistic-like symptoms. And let me say this within the short time that I have. Number one, autism proper is rare. In the DSM, autism occurs 1% to 2% in the general population. So I'm always a little concerned when we see episodes or when you look at some epidemiological studies in autism, we find double-digit numbers. In Philadelphia, when I was in Philadelphia, attention deficit disorder, for example, attention deficit disorder is a rare disorder. It happens less than 5% in the general population. In Philadelphia, the incidence of attention deficit disorder approached 20%. And most of those were children of color. African-American children had an high incidence. Okay, well, let's take a look at the population of psychologists in the Philadelphia school district. Therein may be the problem, you see. Now, in the case of autism, since autism is rare, if autism occurs 1% to 2% in the general population, then we have to expand that to understand that you can have autistic-like symptoms without having the disorder proper, you see. So now there are certain vaccinations, for an example, the exposure to teratogenic substances can, I believe, contribute to autistic-like features, but not autism proper itself.
Let me just expand this question once more. Mm-hmm. What about environmental toxins like manganese, lead, and those things?
Yes. Well, well, the jury is out, Dr. Maxey, as you already know, the jury is out already pertaining to these teratogenic substances and how they can have a negative impact on brain growth and development. The jury is out. Mothers who expose themselves to microwaves, mothers who are exposed to radiation, mothers who are exposed to high levels of stress can have a negative impact on the child's development. I was looking at schizophrenia. I was doing some research or reading some research on schizophrenia. And what they found in the incidence of schizophrenia, they found that mothers who had prolonged labors, very difficult labors in the children, there was a higher incidence of schizophrenia among mothers who had prolonged labors than in the general population. So when it comes to substances like lead, mercury, magnesium, and so forth, can they have an adverse effect on brain development? Absolutely. So we have to distinguish them. We have to distinguish between teratogenic exposure and, say, autistic features, as opposed to idiopathic events in which children are born with autism, which occurs, by the way, statistically in the first trimester of pregnancy. We know in the first trimester of pregnancy whether a child is autistic or not.
Well, thank you so much. We're at almost at the 2-hour period, and we're trying to reduce our time to an hour and a half. We've had a great discussion, and I want to make sure that, Michelle, you got one short question in the chat box?
Oh my goodness, the pressure to pick this one question. Well,
Maybe it should be 2.
okay. So for
But
Dr. Stewart,
we gotta give short answers, doctors.
okay. For Dr. Stewart, at what point is it too late to counteract the ACEs?
Never.
Okay.
There's always something that we can do to mitigate, to reduce the long-term effect, even into adulthood. We can still make some interventions that will really reduce the severity and intensity of whatever has resulted due to that ACEs. A perfect example is for many children who are exposed to ACEs, one of the clear impacts is medical conditions later in life: obesity, diabetes, hypertension, other cardiovascular things. I mean, there's a host of things. If you just search ACEs, adverse childhood experiences, you'll see all of the potential medical conditions. At any point, if we begin to deal with the psychological impact of that, we begin to help people learn how to better deal with those things. People who are obese can get in touch with how to begin weight reduction that actually works. People who abuse drugs and alcohol. One of the things, for example, that I neglected to mention has to do with the prevalence of fetal alcohol syndrome, or fetal alcohol spectrum disorder, where prenatally mom has drinks and that affects the child. We've all heard of this. Well, one of our colleagues who died a year or so ago did a lot of the research to point to one chemical that we can introduce in the prenatal period for that mom who was pregnant before she stopped drinking, before she knew she was pregnant and was still drinking, where those early effects of that alcohol on the early stages of the fetus, that there is one simple thing: a choline supplement in the prenatal vitamin can make all the difference in the world. And this was based on this doctor looking at children differently. That slide where we've all got to think of this differently. He began to look at these children differently and realized that the facial features and their behaviors and their ability to learn and other things were similar, but that if you looked at it carefully and discovered that these were moms who were missing this in their bodies at certain levels, and if you added it in, their children did not get the same outcome. So these are the kinds of things that, as Dr. Villa said, science, evidence can direct our steps to improving the health condition, even with ACEs.
Well, thank you so much.
Thank you, Dr. Stewart.
Let me end our program, but I want to give credit to both of you, and I'm going to invite you both back, not only to give us another webinar, but I'm going to ask that you agree to do a podcast with Dr. Uh, Neighbor Stevens and myself so we can go into depth. There's so much knowledge here that we'd like to be able to post that on our website where each of you can go in depth with the presentations that you have made so authoritatively. I want to end with what we do know that nutrition is so important. And we know that during this period, we know that there's many of us don't get the nutrition we need with the micronutrients. And I recommend as a clinician that people take prenatal vitamins. Now, I'm not pregnant, but I take prenatal vitamins every day because they have all of the micronutrients. I also take vitamin D and I prescribe it. I recommend for people, and you do know that sometimes Black people, because many of us are very dark skinned, that influences how sunlight increases our vitamin D. So early on, I advised many of my patients, many of whom are renal patients, to take 50,000 international units of vitamin D per week for 4 weeks, and then I bring them back to the 500 IUs per day. I also recommend using 2,000 milligrams a day of vitamin C as well. Some people recommend zinc. We're going to post on the website David Brewer's uh, recipes for elderberry, and he adds manuka honey and a number of things, and he gives a warning that if you have collagen vascular diseases and other diseases of your immune system, that may not be a good thing to take. But he represents that he and his 100-year-old mother haven't had a cold or the flu in 8 years just by following this type of regimen. We know that 8 hours of sleep is something that's very good for your immune system. Exercise is very important for your immune system. The social distancing, and we have had several talks that people did tell us that not only is this virus spread by droplet spray, but in fact it's in the aerosol. That means when you can see your breath, if it's cold, it's in that. And therefore it's not limited to just 6 feet. 6 feet is the least you should be close to somebody else that you're not quarantining with, but it can in fact go 16 to 20 feet. It is important to wear masks, and much to the chagrin of many of my professional colleagues, when you wear a mask, it has been shown that you do not decrease your oxygenation, you do not increase your retention of CO2. And this has been proven many times by drawing arterial blood gases. You may feel it more difficult to breathe because you're going against a force, but it does not affect your ability to put oxygen into your body. In addition, you are not catching the disease or infection any worse. All of that is hooey. You need to protect yourself. You need to stay away from other people unless they're quarantined with you in your house. And we've heard in previous talks, we heard today about the adverse childhood events that can affect your immune system. We also heard about the allostatic load, and all of these are true, and we need to heed them. We've had a lot of learning. I hope that you put the thumbs up sign on your various social media, that you like us, that you spread the word, and we hope to continue to bring you brilliant doctors and practitioners like we've heard today. I thank you very much for your attention, and we do need your financial support. It is now tax deductible with the Black Health Trust. We actually have a bank account. I don't know what's in it, but we'd love you to help us. This is not a religious show, but we do ask various people of faith to take us out at the end of our program. And if Miss Brenda Lieger is on, I'd love for her to give us a final thought.
Dr. Maxey, I do not see her on the call today. Maybe is Tori Bailey available? Can you give us the word out? Affirmation?
Can I unmute? Can you hear me?
Yes.
Yeah.
I had put a quote in the chat a while back for you to read. Now, if I can find it, but in the meantime, I give a quote every week to affirm what we're doing. And I think it had something to do with the futurist of information that we give. And I no longer see it.
I see
But
it.
in the meantime,
It's
okay, can you read it for me?
sure. It says, we have to do with the past only as we make it useful to the present and the future.
Yes.
Yes. So may we continue with the wonderful information of the Black Health Trust and see you next week.
Okay. And thank you, our two speakers and my co-moderator and my wonderful hostess for today. Thank you.
Absolutely wonderful information today. I could sit at your feet all day long, but I know you have things to do, Dr. B and Dr.
That
Stewart.
was wonderful.
Thank you so much.
Thank you all.
Have a good week, everybody. Stay safe.